Good afternoon and welcome to the public forum, Clinical Trials, Future Pathways to Better Treatments. This is presented by the Australian New Zealand Gynaecological Oncology Group, or as we know it, ANZGOG. Good afternoon, ladies and gentlemen. My name is Karen Livingstone and I work in development, philanthropy and major gifts for ANZGOG. I have been involved in ovarian cancer since 2001. And with ANZGOG since 2007 as an ovarian cancer advocate. And I was also fortunate to be a board member of ANZGOG for just on a decade. I'd like to start the event by respectfully acknowledging the Gadigal people, who are the traditional owners of this land on which the event is taking place, and pay our respects to elders both past, present and emerging. I would also like to take this opportunity on behalf of ANZGOG to pay our respects to New Zealand and all of its people following the horrific events on Friday the 15th of March. Who is the Australian New Zealand Gynaecological Oncology Group? ANZGOG is the peak gynae cancer research organisation, and as our name suggests, it operates in both Australia and New Zealand. We are recognised as a world leader in our clinical trials research. Operating for the past 18 years, our mandate is to improve life for women with gynaecological cancer through research, cooperative clinical trials, information and awareness. Our research has changed clinical practice both locally and globally. As someone who has been personally touched by ovarian cancer, I understand your need to gain information and knowledge. It is for this reason that I became involved in ANZGOG initially. Today, we aim to empower women and their families to make more informed choices and to better understand ANZGOG's research priorities. We are live streaming this forum on our Go for Gynae Facebook page. These presentations will also be recorded and become a resource on ANZGOG's YouTube channel. I would like to acknowledge the women in our audience and those watching online who are survivors of gynaecological cancer. Welcome. We are privileged to be joined here today by our Survivors Teaching Students volunteers. In 2019, STS is extending its reach north to regional Townsville, across to Perth and to both islands of New Zealand. I also acknowledge the audience members of ANZGOG's Consumer Research Panel, led by Wanda Lawson. The CRP's role is to represent women affected by gynae cancer in ANZGOG's research at every step. Both of these programs, both the STS and the CRP, we love an acronym here at ANZGOG, are integral to ANZGOG, and it ensures women are not only represented but their voices are heard. We will be taking questions today from both our audience and also via our feeds. Please understand that presenters will not be able to address individual medical cases. They can, however, speak more broadly on matters that have been scientifically validated and within their specialties. We will be breaking for an afternoon tea and before we'll be continuing to our second part. And as I'm charged with keeping us on time, if we are running behind, we will shorten that break. Today, I am pleased to introduce you to some of ANZGOG's leading clinical researchers. I would like to point out that this is really important, the clinicians' involvement in ANZGOG, in committees and working groups, is actually a volunteer role. So they're actually appearing above and beyond their clinical loads, and we applaud them for this commitment. To begin our presentation today, I would like to introduce Associate Professor Philip Beale. He is a medical oncologist, the Clinical Director of Cancer Services at the Sydney Local Health District for New South Wales Health, and more importantly for us, in April 2018, Professor Beale became the Chair of ANZGOG. Here to open proceedings, please welcome Associate Professor Philip Beale.
Slides just on there. Slides. Okay. Okay, well, thank you very much, Karen, for that introduction. Yes, it is a great honour and a privilege to be the chair of ANZGOG, and it's a role that I think that I really want to commit myself to completely. And we've just completed our annual scientific meeting, which has been a fantastic 3.5 days of work done by so many people, clinicians, researchers, advocates, everyone who's involved with the treatment of gynecological cancers. And I think the ideas that have come out of that with the view to the future and better treatments, I think has been really inspirational, and certainly I've been really, really happy with that. So I'm just going to run through a few things about our organisation just to set the scene before we go on to the talks. And so I think, as Karen has said, we are now into our 19th year. And we do have now 935, actually it's gone up after this meeting, we're now pretty close to 960 members of our organisation. I think importantly is that research has been conducted now in 52 hospitals across Australia and New Zealand, so it really is the extent of the reach of our research, which is, I think, really important. It's not just in one or two places, it's everywhere across the countries. And I think that this understanding about clinical trials is that really it is the best way that we can introduce new therapies into clinical practice. And I think that we know that the way that we can improve survivals is really only on the back of these clinical trials, because it forms the basis of what we can use as our evidence. It is actually the way we get treatments funded by government, and it is the way that then we can truly make a difference in terms of survival. So just briefly, these are the types of trials that we are involved with, and they are different, and I think it's quite hard to sometimes keep or understand all of those differences. So that first dot point there, the treatment trials, it really is, it starts with the earliest way that we are finding out about the safety of a treatment. We're understanding who it can actually benefit, and then we go on to compare it with other treatments that may be available currently. And so it really does a way that we then go from what we know to how we increase that knowledge to improve our treatments. Prevention trials and the early detection trials, I think, is really what we're really trying to do there is two things. We're trying to both obviously prevent the disease by mechanisms which may be about prevention strategies, which can include surgery, can include medications, and can include lifestyle measures. And it's trying to work out the best pathway for those. And the early detection ones, I think, was one that we're all very, very aware of and keen to know whether or not we really can find that early blood test, urine test, other tests which will be able to really detect cancers at the earliest possible stage where we really can then make the biggest impact. I think the diagnostic trials is sort of an area where we are doing more and more work in now, trying to understand both tests that we can do to help us to understand more of the nature of cancers, so that we can be smarter and smarter, understanding that each cancer may be a bit different, and how we can then use that information to guide therapy for individual patients. And I think very importantly is the quality of life studies which we are doing, so that we be sure that whatever we're doing, whether it be treatment, be surgery, whether it be radiotherapy, whether it be chemotherapy, hormonal therapy, targeted therapy, immunotherapy, lots of therapies, that we just always be sure that we're always asking patients about how they are feeling, what are the experiences they have, so that we do know that we are always balancing those needs against every other aspect of their care. So how do we do it here within our organisation? So we have a series of committees where we have an ovarian committee, an endometrial committee, a cervix cancer committee, and so they are the starting place where we have the ideas that will be actually discussed about new ideas and trials. That then sort of filters down to a protocol that says, okay, we are now asking a question of how we're going to decide how we can answer that question. It then goes to our research advisory committee, who then look at the science of it, look at the numbers, and understand that we are asking exactly the right question. So it's then reviewed. It then we then have to make sure that we can actually do that logistically across Australia and New Zealand, and then we ask all of those sites. Then we finally have a protocol which has to be written and completed. It then has to go to those hospitals and those sites, and it has to be then approved by the ethics committees and their governance committees, and then it can start. So it's a long process. It's a long process, and there's lots of little barriers in there. And I haven't said them all, just by the way. And of course, there is actually, issues which include funding. So the decision about that suitability is made in two ways. Of women's suitability would be, first of all, when we're deciding that trial, we will be deciding on certain aspects of the nature of the cancer and the nature of the patient to decide whether or not that trial is the right one for that patient. But then the treating clinicians who are involved with the care of individual patients will also be in that discussion, is to say that these are the trials that are available and these are open to you in that situation. And so it's a discussion about that, because the doctor, your treating doctor, will have knowledge about your particular situation, which will be very helpful in determining suitability. In terms of the benefits involved in clinical trials, I think some of them are very self-evident. We know that several things, that clinical trials do give us opportunities for access to new therapies, and we do think that that's really, really important. We don't always know about every therapy and how well it works, so there are always challenges. But we also know that from lots of evidence that says that those people who are involved in clinical trials, on average, do better than those who are not. It just seems that the nature of those trials, the nature of the care, is that the data supports that the survival rates are better. So the challenges to clinical trials are many, I think, and I've highlighted some of them, that there are lots of issues, that just getting a trial open is hard work. There is expense in that in terms of all of those steps. There are costs. And then when you're running those trials, you have to have people on the ground to actually help and assist that. And so there really are a multitude of challenges. So just a couple of more slides. This is one of the ways we are trying to get to our trials in a faster way. And we've actually formed this alliance called the Ovarian Cancer Alliance for Signal-Seeking Studies, or OASIS, and that is really a way which we are saying, we've got these ideas, we've got new targets, we've got new ways of thinking about it, we want to actually do those trials, we want to do them quickly, and we've got some funding that we can actually then allocate to those trials. And so that's been a really huge initiative over the last few years, and we've got a number of trials that have actually started on the back of that. We're also doing what I mentioned there about trying to understand the biology and the nature of the cells and doing those work. That's the translational, that's ANZGOG, and again we've allocated some resources to that so we can more reliably collect tissue samples, and we know how to actually test them to actually guide us in trials and treatment. And our fund for new research is now looking at ways we can fund work in the laboratory to help guide us to those new trials. And then when we've got that idea and we're starting out, that we can actually put in some seed funding to do that. So these are all the ways that we have been working tirelessly to get to the way to open more trials. That's it. So I will leave you to this here. I really am really excited by the program, and I do hope that you really have a great forum.
I'm going to get you. Okay. So we will have questions with Professor Beale after the next presentation, and he will join our next presenter on stage to ask questions. So during his talk, Associate Professor Beale has mentioned OASIS. OASIS is an initiative that has been born out of the need to take a different approach to ovarian cancer research to speed things up. With technology advancements in the last few years, we know that ovarian cancer is not one single disease. It is 5 histological types, and then they have their own subtypes. This absolutely adds to the complexity of treating this disease. OASIS is not one trial, but a series of small studies that are seeking a positive signal that enables clinical trials to proceed at a faster rate. With the help of philanthropy, we have been able to commence OASIS in 2015. Then through a significant gift in will from a wonderful woman Rose Varga, herself diagnosed with ovarian cancer, we have been able to grow the number of studies. This is an important, no critical research initiative, and ANZGOG is currently seeking investment of $5 million to further expand the number of OASIS studies that we can undertake. Our next speaker I'd like to introduce. Dr. Ali Freeman is a medical oncologist and PhD student working at Peter MacCallum in Melbourne. Following on from the theme of ovarian cancer, Ali will present our next session, The Future of Ovarian Cancer is Targeted Therapies, the Importance of OASIS, and Introducing the PRECISE trial. Dr. Freeman is the lead investigator for PRECISE, and please welcome her to the stage.
Thank you, Karen, and thank you, ANZGOG, for inviting me to speak. I'd like to all welcome you and thank you for your attendance, and a special hello to all of those live streaming in from wherever you may be. As introduced, my name is Ali Freeman, and I'm a medical oncologist currently working at the Peter MacCallum Cancer Institute in Melbourne. I am also a PhD student, so after all of these years, I've become a student again, which is a challenge and also quite a reward. So I'm just entering my third year of my PhD, and today I'm going to talk to you a little bit about ovarian cancer, which is my area of sub-interest, and talk to you also a little bit about the PRECISE study, which has been recently funded and supported by ANZGOG and OASIS, and a study that we're hoping to open around Australia in the next 2 months. So hopefully I can get this clicker to work. We've had some issues this weekend, but it's looking perfect. So what do we know about ovarian cancer? And I just thought I'd start by asking for a show of hands so I could get to know the audience a little bit better. But who here in the audience knows someone who's had ovarian cancer or has been personally affected by ovarian cancer? Great, wow. Great and not so great, I should say. I guess for those live streaming, that was the majority of the room, and I guess it's a really important point for us to be aware of ovarian cancer, and wonderful to see so many people who've been personally or somehow connected with ovarian cancer to be here today learning more about what we're doing to improve things. So this is a challenging slide to always put up, but I think it's a very important slide because if we don't discuss the challenges, how can we improve upon them? And what we know with ovarian cancer is that through excellent surgery, we hope to cure patients of ovarian cancer. But the unfortunate reality is that many patients do recur. And when they do recur, we know that the survival rates still have quite a ways to be improved. This is a graph showing that after recurrence, patients at 5 years probably have a 13% survival rate, which is actually very, very low. And this is a little bit of historical data, and certainly I don't think this reflects a current patient coming through a diagnosis and cancer treatment. But again, I highlight this so when we come to the end of this presentation, hopefully our outlook will be looking a bit brighter. So why has this been such a difficult disease to treat? And I guess the background is really that we thought ovarian cancer was one disease, as Karen alluded to. We thought anything that occurred around the ovarian structures was an ovarian cancer, and we treated all of these diseases as one. But what we now know is that there are 4 very different types of ovarian cancers that look different under the microscope, that behave differently when we treat them with chemotherapies. And we know that they actually have different responses to treatments and really have different unique molecular features that we can study in the lab. Highlighted here in red is high-grade serous ovarian cancer, which potentially many of you have been involved in someone's care with high-grade serous cancer. And this is the focus of my research because it's a very common, actually the most common type of ovarian cancer, and it's a very challenging cancer to treat in the clinic. So as alluded, we're learning more about ovarian cancer, and what we see here is a complex, what we call a pie chart. And if you look here on the upper right-hand corner, this highlighted section in red illustrates patients with high-grade serous ovarian cancer that have what we call a Braca mutation. Now, for the sake of time, I won't ask for another show of hands, but I suspect if I asked how many of you knew something about a Braca mutation, that would be the majority of you, which is fantastic. And this graph, I guess, I used to illustrate how much understanding we've developed about high-grade serous cancer. And particularly, again, my area of research in this red box is patients with Braca mutations that traditionally should respond very well to treatment and can also be treated with targeted therapies not just chemotherapies that can treat cancer cells globally, but therapies that can really hone in on these Braca mutated cancer cells and work to improve outcomes specifically for patients. So this is a schema that I love showing because it actually shows how the management of ovarian cancer has changed significantly since I started treating ovarian cancers. And just to walk you through the top of that, as we are aware, patients often present with advanced disease because of symptoms. They undergo surgery, followed by chemotherapy, and traditionally we would observe patients very closely, acknowledging that there was a chance that the ovarian cancer could come back. And should the disease become active again, we would discuss surgery if it was felt to be suitable, but in the majority of cases, we would discuss more chemotherapy. More recently, for patients with Braca mutations, we've identified a targeted drug called PARP inhibitors, which is a class of drugs that we know can be very effective in maintaining cancer control in patients with Braca mutations. We now have access to this drug for patients who have a Braca mutation and who've responded to second-line chemotherapy, and this is funded through the PBS here in Australia. Most recently, though, and very exciting, is some data that's come out from a study called SOLO-1. And what that data has shown is that if we use these PARP inhibitor drugs earlier in the treatment setting of patients, we actually see better control in the maintenance setting. So we see almost a year and a half of prolonged control of ovarian cancer if we use it actually after the first line of chemotherapy, when we've already obtained a response from chemotherapy in patients. The challenge is this drug is not yet PBS funded, and as an organization and as a group, I believe we'll all be fighting very strongly to get access to this drug for patients. But the good news is we can access it now currently compassionately, case by case for patients. But the challenge is, even with these new targeted drugs, cancer is still very clever, and it can develop ways to become resistant. We say in this slide inevitable, but I'm hoping the next time I present this, I can change the wording of that to say that not always the case, that potentially we can really maintain ovarian cancer control better than we currently can. But this slide is a complex one, and it actually reflects some of the research done in the lab where I'm doing my PhD several years ago before I joined the lab. And I'll walk you through it, but the schema is just there to refer back to. But what this research did was it looked at doing complex genome sequencing, so looking at the DNA structure of patients with high-grade serous ovarian cancer, and looking at samples when they were first diagnosed with cancer, and samples after they'd been treated with chemotherapy, and samples at the time when resistance developed. And these studies were looking to try to understand why this happened, how we could target these mutations or these resistance mechanisms as we refer to them, and how we could improve treatments and outcomes. Now, highlighted in the top box are the most common two types of resistance mechanisms. On the left-hand side, you'll see what's called a Braca reversion mutation, which is really just another DNA abnormality that can occur in the Braca gene that's already affected. And what that means is if you develop another Braca mutation in the mutated gene, treatments that targeted that Braca abnormality may no longer work. And so we have to be one step ahead of this potential for resistance developing. On the right-hand box is another complex mechanism of resistance, but what we believe can occur in up to 30% of patients who've had chemotherapy for recurrent disease. And this is referred to as an ABCB1 fusion. Again, in science, none of our names are particularly attractive, but that one's not so bad. But what an ABCB1 fusion means is that a DNA abnormality can occur in the cancer. And there's what we call a translocation, or a move of some of the DNA coding elements. And that actually drives what we think of as a drug pump. So what that means simply is that if you have a treatment going into your body to treat your cancer cells, and it develops this drug pump, the cancer cell can push the drug outside of our control, and potentially still grow and become resistant despite continuing that treatment. So it's very important that we identify patients who have these pumps so that we can try to target them with drugs that potentially don't get pushed out of these pumps if this fusion abnormality occurs. And so why is that relevant? Well, in red are all of the chemotherapies we believe that are actively pumped through this ABCB1 fusion should you develop a fusion abnormality. And that's quite a lot of the drugs that we use in ovarian cancer treatment. paclitaxel, Calyx, etoposide, and some of the PARP inhibitors, and in fact the one PBS-funded PARP inhibitor we currently have called olaparib. So the challenge is if you have a fusion, we are concerned that these drugs may no longer work and may explain why patients have become resistant. So if we could find a drug that worked in this setting, that wasn't pushed out through this pump, we may potentially be onto something really good for patients. And for me. So now this is a complex slide, but we'll run through this together. But that translational background, or that lab research I've just been referring to, really led to the generation of what we call the PRECISE study. And the PRECISE study, again, is a terrible long name, but we've abbreviated it, and it basically stands for the use of a new PARP inhibitor called pamiparib in patients who've developed this drug pump, who don't have a BRCA reversion, and who've recently stopped responding to their current chemotherapy or their current olaparib or other substrate PARP inhibitor. So those drugs in the previous slide in red. And what that involves, it's not easy for patients. We're targeting a very small population of patients, but we're doing it because we think it's going to be the right treatment and we think it will be effective. So what that involves is getting a patient to hear about the study and going through the process of what we call pre-screening. And what that means is meeting your oncologist, reading some information about what the study pre-screening steps involve, taking the paperwork home, discussing it with family, friends, and loved ones, and considering whether it's the right match for you. Now, the complexity is pre-screening doesn't mean that you're going to get onto this study or that you're going to want to participate necessarily, but it means looking into your cancer biology and your cancer cells to see if potentially this study may be a good match for you. And the challenge is, again, that to find out if this is a good match, we actually need some tissue from the cancer. And we think because these resistance or these challenges in treatment responses over time evolve, and so the tissue we may have had at the time of diagnosis may not reflect what the cancer is doing now. And so we need new tissue. And so how we propose to do that is through a biopsy, using a CT scan to guide a needle in to get some tissue, or potentially draining some fluid from the belly if that's easily accessible. Those samples will then undergo complex testing looking for this fusion and the lack of a reversion, and that time will take about 4 to 6 weeks at the longest to get the results of this study. Now that's a difficult time because we accept that patients may be starting to have a rising CA-125, but we've certainly planned for that and allowed patients to continue and be able to have treatment while they're awaiting the results. When the results come back, we will then discuss the results with the patients, and should they be found to be eligible, we then go through what's called a screening process to see, again, if it's something that patients are interested in doing, again, if they meet all of the safety criteria, and again, if they'd like to participate. Once on the study, all patients will receive the study drug pamiparib, so it's not a randomized study. There's no placebo. It's an active therapy for all comers. We've divided the study into 2 small groups so that we can ensure that we're really learning more about the disease and looking at patients who've started to have disease resistance most recently on olaparib, or disease resistance most recently on chemotherapy. So we've purposely tried to create space for 2 different subsets of patients so we can see if there's a difference in benefit. I guess the other novel thing about this study is we know this drug, it's been through trials already, but we don't have a lot of information about what it does to patients over time. And so we'll be using some of the most questionnaires, which are questionnaires that patients will be asked to do throughout the study to ask what their current symptoms are from their disease, what current side effects they may be having from treatment. And this is a really important part of the study to see if not only is it a good effective drug, but if it's well tolerated. Another novel part of this study is acknowledging that pre-screening is difficult. We accept that patients have to go through this to be selected for this study because the tests take a few weeks to get the results of. What we also suspect is that it's a terrible time for all of us, and so we want to assess that formally. And we'll be asking patients to take some questionnaires, assessing their levels of distress and anxiety about going through the process. Because as ovarian cancer research develops, I suspect many, many more of our studies will be more specific and more targeted for patients And so we'll see quite a few studies like this that may be selected for very specific groups of patients. And we need to know what this does. I think we suspect that it's stressful and it's distressing. I know it is for me, waiting for the results to give to a patient. But we need to document this clearly, and we need to see what supports need to be put in place for patients during this difficult time. So there'll also be a few sets of questionnaires for patients undergoing that process so we can better comment on this situation and address the needs that need to be met. So I guess I've spent a bit of time highlighting the PRECISE study, but what I've not talked about, and I think it's an important part of the OASIS initiative and ANZGOG's drive for future research, is the part of this graph here in blue. We suspect we need to screen 200 patients, so request 200 patients to have biopsies to be able to find the 40 patients that we think we need for this study to prove whether or not it's an effective treatment. That means 160 patients will not be suited for this study. But by participating in the pre-screening process, not only will we be learning more about anxiety and distress and how we can improve upon things in that process, but patients will also be offered the opportunity to co-consent into another study that many of you may participate in or be aware of, called the Australian Ovarian Cancer study. And that's a very large study with thousands of women around Australia looking at collecting patient data, clinical outcomes, and tissue from patients who've kindly volunteered biopsies or blood samples over time. And so this blue section of the study is really valuable because we'll also be able to learn how patients who couldn't come onto the study respond to other treatments, because there's currently one published review about how patients respond after a PARP inhibitor. And so a lot of what we do at the moment is our best guesstimate, and that often relies on going back to a chemotherapy or thinking of another clinical trial. So there'll be an invaluable amount of research driven from this study, even for the patients who don't participate in the actual study drug. So I guess taking you to my final slide, how has this been possible? I hope I look very young. That was the plan today, but I obviously am very young. No, but I'm a more junior medical oncologist, and I'm very invested in research, and ANZGOG has been a fantastic support getting me through to getting the trial where it is today. If you can believe it or not, the idea of the study really came about 1.5 years ago, which is a remarkable turnaround time from a concept being drawn up on a whiteboard not too dissimilar to the one over there, to now being able to stand here and say to you that we have ethics approved, we have an agreement, we have funding through ANZGOG, we've got drug from the pharmaceutical company, and we've had a lot of fantastic support to get it that way. So this is another terrible plot that we're actively changing, and I am very hopeful that the next time I get to speak to some of you in this audience, we'll have some exciting results to tell you about from the PRECISE study. I guess I want to thank you for supporting ANZGOG and for being here and attending virtually, because without this passion from you, our research would be meaningless. So I thank you all very much for your attention, and I look forward to answering any questions in a few minutes.
So we're just going to invite Associate Professor Beale to come on stage as well, and we'll ask you for some questions, and both Ali and Phil will be able to answer. We have the mics, girls. Is there any questions? No? None from online? Okay.
I have a question.
You have a question?
That study that you were talking about, that's only for people that have the Braca mutation?
It is. So the question was, is the PRECISE study only for patients with Braca mutations? And that reflects a really important point, that we think that PARP inhibitors can be an effective drug in patients without a Braca mutation. I guess when you have evidence like that, the question is, how do you devise your trial? And what we think, to not lose an important signal in a new drug in a new space, is to try it in the group of patients we think it's most likely going to work. And that's why, again, this is a small study, 40 patients. But if we find signs that it's effective, obviously we want to expand that indication and who can get access to that drug. As I illustrated previously, how PARP inhibitors have moved from after the second line of chemotherapy now to the first line of chemotherapy in patients with Braca mutations. things are changing quickly, and should there be a good signal from this study in a group we hope will be responding, that obviously we would be opening it to, in a larger study, to other patients and potentially other cancer types, because we know that these fusion abnormalities can occur in breast cancer, prostate cancer, a few other cancers. So it has a lot of potential for reaching out to a lot of patients. Great question.
Is there targeted therapy for patients without a Braca mutation?
That's a good question.
Well, I mean, I think that is indeed, currently there's not specifically a targeted therapy for that group, but that is indeed what we are trying to do, especially through that collection of tissue, where we are now with a number of programs identifying lots of changes in the cells so that we can identify those and then get the drug that will target that. But that's the sort of link between the new treatments and finding out about the biology of an individual case.
Do you have any idea what the timeline is for the PARP inhibitors to be available to people who have had first-time chemotherapy and then
Well, it is available now, but only on a compassionate basis. So it is available, but it's a sort of a specific application process rather than just the normal prescription process that we would do through the PBS.
And do you have an idea when it might be available for people that might not get it through the compassionate reason?
Through the PBS?
Yeah.
Well, the PBS takes longer. It's a longer process. It would be in the order of 12 months is the sort of time frame you might think, but it might be accelerated. We never know.
Okay, thank you.
So we're talking about high-grade serous. Are there any thoughts about PARP inhibitors with low-grade?
Well, what we know is that if you, in the studies that have been done, again, all the AOCS that Ali referred to, that when we look in the number of Braca mutations in those other types is really very small, very rare. There's a few, but they are very rare. So we won't, those other types do not tend to have the Braca mutation. So currently where the funding is and where the drugs are, that's not available. But would some of those cases be susceptible to the treatment, meaning could they have some susceptibility, again, which Ali was talking about, the other types of abnormalities? The answer is almost certainly yes. But that's still a work, unfortunately, that's a work that's going forward. There's more questions?
What's the state of play at the moment with immunotherapy?
Well, I gave a talk actually at a patient forum actually like this in Brisbane just last year, and we talked about immunotherapy. The moment about immunotherapy, if you just say, here is the immunotherapy maybe you've heard of, in the media and has been used in melanoma and in lung cancer, the answer is that it doesn't work very well. The response rate, like in terms of tumour shrinkage, 8%, only 8. So it's not, in its current form, it's not, we don't think it's the right treatment, not for ovarian cancer. But even since I gave that talk last year, there have been a trial where they did look at giving immunotherapy with some chemotherapy, so like 1 dose of chemotherapy and some immunotherapy, and the response rates went right up to 30%. And so, okay, maybe there are ways which we can make it work better, but we still don't know that in enough detail, and it's not available still yet to be given to patients. But there is also, in people who are having chemotherapy for the first time after the diagnosis of ovarian cancer, immunotherapy trials are now being done to look at the effectiveness of immunotherapy given with chemotherapy right at the very beginning. And there's a huge amount of effort going into that right now.
What's the Braca thing? How are you discovering it at the moment? Mainly from the breast cancer side, the Braca there, and then saying, like, we look at cancer in the ovarian cancer. Do we go from one to the other, or can you just discover it without going that route?
I think the answer is that we learn lessons from each cancer, and because there are some similarities, but there are also quite a lot of differences as well. So there's a lot of cross-fertilisation about understanding the biology and the nature of different cancers like breast cancer, or whether it be bowel cancer or lung cancer, and that then will feed into the information that we have from ovarian cancer. So it's a cross-fertilisation of ideas, but acknowledging that some things work in one cancer but don't work in another.
So mainly if you do come across it, it's an accident for some other procedure, and then you find ovarian cancer?
Do you mean in terms of the detection of it?
Yeah.
Sorry, I misinterpreted your question, sorry. Yes, so the detection of ovarian cancer, you're right, is really very hard, because at the moment the symptoms are quite non-specific, and we know that the vast majority of women who are diagnosed have more advanced disease because it is very hard to pick up at its early stage. So it's either, yes, by accident in the early stages, or it's unfortunately with symptoms of more extensive growth in the later. It's certainly advanced at that stage, yeah.
I just have a question about the tissue samples. Is that just happening as a matter of course through surgery, or is that the Innovate trial, or how are the tissues being gathered and tested and analysed, I suppose?
Well, look, I think so. There's two things maybe. I think in Ali's study, the biopsies aren't new biopsies, so they have to be identified in the current state. You know, so if there is a regrowth, then the biopsy would have to be done on that new growth. Innovate is a study which is it's a great initiative run through Anna DeFazio at Westmead, and it's looking at taking the tissue at the time of that initial diagnosis, so like at surgery. So from the surgery, that specimen then will be, with the appropriate consent, will be then taken to that laboratory, and some of the work that Ali has just highlighted would then be done on that tissue, so we have the knowledge of the cells as early as possible, so that we can hopefully be as smart as possible, but saying, well, okay, there is a Braca mutation, or there is another mutation, and we can find a way of then being able to target that. Sorry, I was
Is the PARP therapy an ongoing therapy, like maintenance
in the trial?
in the trial?
So I'll answer a question. It is. So
Right.
as long as the patient is responding to the drug, tolerating the drug well, they'll be able to continue the drug. And you know, the only situation that would change would be if the drug came on the PBS and became accessible, or if something extraordinary happened with the study where we had to find a different way to access it very quickly.
Thank you very much.
I feel like I've neglected people here. There was a question.
Okay, you've got time for just one more, because we are running behind. Sorry, I couldn't make it.
I just want clarification about one of your slides that you put up. You had, where you had the pump and you had a table with all the different drugs. The top band said yes, the bottom band said no. Can you explain what does the yes mean, what does the no mean?
So the drugs at the top in red were drugs that we think can be pushed out of this drug pump should your cancer develop this fusion. So we think that if you have this fusion and your cancer stops responding to current treatments, it's likely to be one of those treatments bolded in red. So two of the big treatments in ovarian cancer, carboplatin, gemcitabine, cyclophosphamide, don't seem to be pushed out of that pump if you develop an abnormality. So it may be the case that patients would be on those drugs, and when we biopsy them, may or may not have a fusion. So it's just something for us contextually to think, particularly when we look at those patients who may not go on to the study and assess their response to subsequent therapies.
Thank you.
Thank you very much. Thank you both to Associate Professor Philip Beale and Dr. Ali Freeman. We're now going to turn our focus to cancer of the uterus. This disease is also referred to as endometrial cancer. The lining of the uterus is called the endometrium, the most common of all the gynecological cancers. It is, however, increased in 50% in the last 10 years. There are significant lifestyle risks associated with this cancer. ANZGOG has a strong research focus on endometrial cancer, including an ANZGOG clinical trial to evaluate the benefits of exercise on women who have been diagnosed. Dr. Di Adams is our next speaker. She's a medical oncologist with a specific interest in survivorship care. She is a member of the Clinical Oncology Society of Australia Exercise Committee that has released the position statement last year calling for exercise to be part of routine cancer care. She's coming to talk to you. Please welcome her.
Thank you very much for allowing me to speak today. Yes, I'm going to take my luck with the clicker because it was causing a few issues earlier. Right. So I'm going to talk about obesity and exercise in gynecological cancer outcomes. So a complete change of tack. Move over tobacco. Obesity is on its way to replacing tobacco as the #1 preventable, modifiable risk factor for the cause of cancer. And endometrial cancer is the leading type. So this is way beyond colorectal breast cancer down at the bottom, gallbladder, kidney, pancreatic cancer, adenocarcinoma of the esophagus, and endometrial cancer is at the top. So bowel cancer's got a sign saying, does obesity really cause cancer? So yes, obesity can cause cancer. Not everybody who is obese who has developed cancer because they are obese. It's really important to understand that. But if you are a woman and you still have a womb and carry extra weight, you and your doctor need to think about how to reduce your risk of endometrial cancer. Important, the doctors involved. They need to help. Because we actually know the higher the BMI, the greater the risk. The greater the risk of developing it, and once you've developed it, the higher the BMI, the more aggressive the cancer is in terms of actually likely that it's going to kill you. So it's really important we think about how to improve risk and reduce BMI. And in America, they actually have published that the lack of exercise and being overweight can lead to endometrial cancer. 3 out of 5 women have developed that cancer because they have carried extra weight and have not taken as much exercise as perhaps we had recommended. So in Australia, there are 1,800 women diagnosed who perhaps, if they had not carried extra weight and had taken more exercise, could have been prevented. But is that message being given to women? So as you can see, the bowel cancer poster showed to lose weight, but are we actually advocating that to our women who carry extra weight? And in just over 20 years, obesity rates are up and uterine cancer incidence has risen by 20%. And the concerning part is that the high obesity rates are actually developing at a younger age. So we're actually seeing younger women diagnosed with endometrial cancer. So 35% of young women are obese. And so if you ask any of the gynae-oncology surgeons that are operating, they are seeing younger women. This is not genetically related. This is not Lynch syndrome. This is because they have carried extra weight and no one has discussed with them the risk that they carry as a result of the extra weight. So about 5 years ago, I actually spoke at ANZGOG about this concept of an endometrial tsunami. So there is a current wave of women diagnosed with endometrial cancer, but I think there will be a bigger wave of obese young women who now are exposed to the risk of endometrial cancer, and we need to get that message out. So I think the average age of endometrial cancer at diagnosis is going to drop. We haven't yet seen it, but that's what's being reported by a lot of our colleagues. I'm now going to talk about not all fat is created equal. It goes back to the old apple and pear. And we actually know that in the apple figure, that is where you actually carry fat centrally, and that's called visceral fat. And that is not as friendly as old subcutaneous fat around your rear end and just on the skin. And that's a problem because central fat is a metabolically active organ. It's a shame it's the only metabolically active part of one, but but that's the concern, because metabolically active fat is bad when it comes from your central abdomen. For the same reason that it drives cancer, hypertension, insulin resistance, and type 2 diabetes, the same process of inflammation can drive cancer. Sorry, that's a guy, but I actually couldn't find a little figure of a lady, so I do realise that. But we know that this inflammation plus estrogen, and we do have higher levels of estrogen. If you have more fat, you aromatise your fat into estrogen, plus insulin, plus equals this obesity-driven cancer. So what's the impact of having obesity and being a survivor? Well, it can affect your quality of life, and it can add to the morbidity of the cancer treatment. If you're a young woman and you haven't yet had your kids, it can affect your life in a major way because it might affect your fertility and ability to have children. And actually ANZGOG's got an excellent study which is looking to see whether they can reverse early endometrial cancer changes, and it's called the FEM study. So ANZGOG is already looking at that. It may impair the delivery or the benefit of therapy. So 10% of women who are actually what we would describe as morbidly obese can't actually have any therapy at all because of their end organ damage from diabetes or heart disease. And we've actually seen that it can actually increase the recurrence or aggressiveness of some cancers, not just this old-fashioned type 1 endometrial cancer, it's actually type 2 endometrial cancer, which was a new find for us. So we are concerned it's actually promoting the aggressiveness of the cancer. But the big thing is that actually the cardiovascular disease is the leading cause of death amongst survivors of endometrial cancer. And is that message actually getting out? So we know that when a patient is diagnosed with cancer, the majority of people are actually entering into a cancer diagnosis insufficiently active. We then find that the majority are actually experiencing declines in physical activity levels during treatment. It's fairly obvious because what you go through, it makes you exhausted and you don't really want to necessarily exercise. And then a lot of people actually never regain their pre-cancer physical activity levels, which were not actually that high to start with. So how do we change this paradigm? This is where exercise comes in. We know that exercise is one of the best medicines you can take beside your cancer treatments. And one person has actually described it as the missing link between cancer treatment and living a well life. So I would actually advocate that exercise should be a core part of routine gynecological cancer care. So just like your surgery, your chemo, your radiation, exercise should be in there. And that's what we are calling for as a community, particularly from the COSA, which is the Clinical Oncology Society of Australia. Because, and this is famously described by Prue Cormie, who's the lead, if it was a pill, we'd all take it. Yes. It improves our energy levels, it reduces fatigue from cancer and its treatment. It improves the ability to tolerate cancer treatments and receive the full dose. We actually know you can get more dose in if you exercise. It actually maintains and increases muscle mass, it reduces fat mass, and it improves this sort of healthy muscle to fat ratio. It improves your physical fitness, cardiorespiratory endurance. It improves stress levels. And they're all pretty high when you're going through treatment. And it potentially will improve your survival. So we know potentially in breast cancer, bowel cancer, and these are all sort of epidemiological studies looking at many, many thousands of people, but also looking at trials going on, that it can actually improve your survival. And so there is the ECHO study, which is also looking at that as a secondary endpoint. It can improve your quality of life, and it can lessen the impairments on the function that the treatment has caused. And the most important part is it's actually safe during and after treatment. It's really important because a lot of people go, oh, I don't know whether I could do this because I don't know if it's safe. You know, is my doctor going to allow it? So I'm going to dispel that myth. Exercise isn't a pill, so it's less likely to be funded by the drug industry. They don't get any kickback for this. So unfortunately, all those millions of dollars that very kindly they fund for many, many pharma studies and all these development of new drugs, unfortunately, exercise does not get that funding. So it does rely on trial groups like ANZGOG. So this is an example of an ANZGOG-funded study to look at exercise. I'm not sure how many people might have participated in the ECHO study. Does anybody participate in this study? It's for ovarian cancer. It's tracking very well. And it's looking at the effect of exercise during chemotherapy on the physical well-being for patients on first-line treatment of ovarian cancer. So, exercise as a treatment. What does it do? It maintains and increases muscle mass. Why is that good for us? Because it can prevent falls and fractures. So who feels more like the bird on the left? So the problem is that a lot of our chemotherapy drugs that we use in gynecological cancer can actually affect our nerve endings and give us balance problems. So taxanes and cisplatins can cause neuropathies. And what's really important, and I've just included a few articles, a few trials. This is a paper from a few years ago talking about the falls, functioning and disability among women with persisting symptoms of chemotherapy-induced peripheral neuropathy. That's the tingling you might experience. But actually the bigger picture is what happens if you've had that and it's persisting, is what happens to your balance and risk of falls in the future. And actually if you exercise and you maintain your core strength, you are less likely to fall over. So it's that shut your eyes and are you going to wobble and fall over? You've lost your balance because of the chemotherapy, and if you actually exercise and you improve your core balance, that potentially would reduce that risk. So we know that rehab focused on strength and balance training is known to prevent disability and falls in older people and in people with neurological conditions, so we should be including it in our cancer care plans. What about cancer as a treatment that maintains and increases muscle mass? How can that help your immune system? So everyone's talking about immune therapy. Well, we actually have our own immune system that we can mobilize through exercise. So they're called natural killer cells. They're natural born killer cells. They are our first responders, and they go out and they seek infection, they seek out cancers, and they're actually now looking at trying to improve natural killer responses. Just like these things called CAR T cells, they're trying to do the same things with natural killer cells, but we actually know that exercise can make natural killer cells respond better. So if you exercise, you make your natural killer cells work harder. What about exercise as a treatment to counteract weight gain? Treatment-induced menopause. Oh, that's a scary thing, menopause. I'm beginning to experience it, and it's not much fun. So all those kilos, so exercise can help counteract that. The steroids we give to counteract some of the side effects of chemotherapy, dexamethasone. And also the development of this syndrome, it's called the metabolic syndrome, where you get insulin resistance and chronic inflammation, and it's that going back in that chicken and egg and sort of stimulating cancer cells. I would like to say that exercise can be fun. The dragon boaters are the best example of this. Heather's a wonderful other example of how exercise. She can go to Kilimanjaro and run up hills and you can enjoy yourself. So it's not meant to be boring exercise. You've got to pick something that you want to enjoy. And the dragon boaters are a great example. It's a source of social support during and after the course of treatment. You can build and maintain relationships at the time of your cancer, and it might actually help you deal with the effects, how the effects of cancer are dealt with. It's like a problem shared. Do you need permission from your oncologist or surgeon for exercising? No, but it could assist with communication. Should your doctors be discussing exercise with you? Yes. The Cancer Institute is telling us that we need to discuss exercise with our cancer patients. So they are evidence-based, and they are telling us to do it. Are we doing enough of it? I wrote an article 3 years ago. No, I think we need to do more. But are we talking about it enough amongst our patients? So that's why we came out with a position statement last year from COSA, which calls for all members of the multidisciplinary cancer team to promote physical activity and recommend that people with cancer adhere to exercise guidelines. So that's nurses, clinical psychologists, your occupational therapist, everybody. It's not just the doctor's job, although the doctor should be recommending it. It is everybody's responsibility to be recommending exercise. But we know there are barriers. If you've had abdominal surgery, it's like, well, what can I do safely without potentially having those wounds undo? What about how I feel, being a bit constipated on treatment, or I'm going to get diarrhea, I don't want to go to the gym, just in case it's a very difficult thing to deal with all of a sudden. What's my pelvic floor doing? And also, how do I deal with a PICC or a portacath? So, here I am telling you to take exercise, and you're saying, like, when hell freezes over. So how can I get you to embrace this, and how do we do it? Well, we have to get the right person. Not everyone has experience in exercise for people with cancer or gynecological cancer. Do not go to your local gym trainer who does not know anything about cancer and also does not necessarily know anything about gynecological cancer. You need a person who understands what you have been through. You need to go to an ESSA accredited exercise physiologist or physio who can build your confidence to feel safe and comfortable doing exercise. You can go to the gym trainers afterwards, once you've got your plan and you're safe, do not go to them first. It's really important because ESSA accredited exercise physiologists and physios have actually gone through university of how to prescribe exercise to people with chronic diseases. And unfortunately at the moment, not all of them are based in hospitals. The exercise is prescribed like a medicine. They tailor the outcome. Are you trying to prevent fatigue or are you trying to build up muscle mass? And they individualize it, just like a certain medicine that you're taking. So the type, the intensity, and the volume, it's really important that it is tailored to you. The intensity might be how intense the aerobic side is, and the resistance could be how many weights or repetitions you're doing. And interestingly, we actually know that all people respond to exercise, but actually those with the worst symptoms and the highest level of fatigues are the people who benefit the most. So questions for your exercise professionals. How long would it be before I start to see some benefits from the exercise program? How many appointments are we going to need, and how much will it cost? Well, how much does it cost? So there are benefits through Medicare. Medicare can pay $5 per year, and health funds can also pay for exercise physiologists. You should also flip it around and think about this as an investment for your physical and mental well-being and to manage any other chronic diseases you might be experiencing. So some people describe it as my health insurance policy, particularly if you're going to face treatment again in the future. You'll be fitter as a result if you have to face treatment in the future. The most effective approach is to be supervised by an exercise physiologist or physio, should be convenient if possible, and ideally in a cancer-specific group, a shared experience of cancer is noted to help a lot of people. So these are examples around Australia. So you've got the YMCA and YWCA up in Queensland, you've got the Enrich program in New South Wales, you've got XMed in Victoria, and there are programs all the way around Australia similar where you can go into exercise programs. This is my program I run down in our cancer centre with our exercise physiologists. It's called Active Survivor. I just have one more comment, which you might go to the gym, but if you sit on your bum for 12 hours a day, what are you doing to your risk? I think that meerkat's pregnant, but I had to find out. I wrote fat meerkat and it says... So if you sit after your cancer diagnosis of bowel cancer, you actually carry a 62% higher risk of dying from your cancer. We haven't seen these studies with endometrial cancer or any other gynecological cancer, but it's a worry given the fact I've just said there are some similarities. So I would just like to say that I may have been preaching to the converted. Sorry, Heather. But all I wanted to say is exercise is safe if you have had cancer, but you need the right person or people to help you. Thank you.
Okay, questions. Do we have any questions to Dr. Adams? Yes?
Do you think that message is getting across? Because I was diagnosed ovarian 2 years ago, and I was quite active at the gym at my time of diagnosis, and I was actually told to stop going to the gym due to immunocompromise.
Yes. Yeah.
And even these days, like even my oncologist has this time I'm allowed to go to the gym. That was nice, the last round of chemo. But I think, that message still isn't getting out there enough. So have you got some ways of trying to spread that message?
So COSA is planning to implement the exercise position statement this year, where there is a committee to actually try to implement exercise whereby all cancer centres and oncologists and surgeons will understand the benefits and how to actually apply this. The question of the gym is an issue, and we just say, look, you have to have good hand hygiene because obviously you don't want to contract something. But it shouldn't be that you can't attend a gym. And then I guess the other thing is whether you attend a group session with other cancer patients where they are also more aware. But yeah, you have to wash your hands after training. You have to make sure that everything's clean, so you're not exposed. But no, unfortunately, we would be recommending counter to what you've been advised. However, all the exercise you did beforehand will have set you in good stead.
all right, I go to the gym.
Yeah.
That's really interesting about the Medicare rebate access. So do people can they get that? Can people get that through their oncologist, or they need to go to their GP?
No, it's
what's the process?
Through a GP. So
Through the
it's
GP?
from it's a primary healthcare
Yes.
plan.
Okay.
It used to be called an EPC. It's got
Yep.
a very long name now. So long as you're not getting your toes done,
Yes.
or you're seeing a psychologist on the same plan, because
Yes.
you're only allowed 5 per year for any sort of particular allied health. And so you do have to pick what's the priority for you. But, you know, it is there, but we can't provide it as oncologists, as specialists. It has to come via the GP.
So just to clarify then, that's the same plan that would cover a psychologist. So if you've got a psychologist referral, you can't do that. And if you are approved, is it done in a public hospital? Or is it?
So there are hybrid models. So there are
Yep.
some. I'm quite unique where I work, where we have an exercise physiologist that works in our
Yeah.
centre. Lifehouse also has an exercise physiologist, but no, it's something that we're also calling for, is to get exercise physiologists within hospitals where possible. So this isn't just something that's in community, although in the majority of people, we're trying to actually encourage people to participate in community and not necessarily have to come back to hospital, because not everybody can come back. There's geographic distance, and the other role is whether we can do it through telehealth.
Good work. Thank you.
Oh, there's one. We've got time for one more question.
Vivian.
Thanks, Di. Great presentation. I have a question about the amount of exercise. Is something better than nothing, or is there just an amount that you have to do to make a difference?
Something is definitely better than nothing. So the recommendations are to take physical activity. The guidelines at the moment are relatively open, because it's talking about sort of 150 minutes of aerobic exercise per week and 2 resistance training sessions per week. But I think it does have to be tailored, because obviously if you're losing weight, doing 150 minutes of aerobic exercise may not actually put any more sort of muscle back on you, whereas if you did some resistance training with good nutrition, you'd actually get that muscle back. So it does have to be tailored according to what the problem is, and that's why you need it prescribed by an exercise physiologist. ESS is producing an update of their guidelines as to recommendations. So it does depend on the problem that you have, because you don't want to be doing something that might actually detriment you.
Okay. Thank you very much, Di. I appreciate it. Thank you. So our next speaker, where there has been much in the media recently heralding that Australia is on track to wipe out cervical cancer in the next 20 years. So whilst we're patting ourselves on the back, we need to realise that there is still a real need for women in relation to improving cervical cancer treatments. In 2015, ANZGOG designed trial for cervical cancer Outback went global. It recruited 926 patients across 7 countries. This was the first Australian-designed international recruited trial in gynecological cancer, and it is still active, but recruitment has closed. Our next speaker is Dr. Michelle Harrison, who is a medical oncologist at the Chris O'Brien Lifehouse and Liverpool Hospital. She's going to present, with the advent of immunisation, why is it necessary for cervical cancer trials to continue? Please welcome Dr. Harrison to the stage.
I'd love my presentation. So just while my presentation is getting on, I'd like to thank ANZGOG as well as Karen for inviting me to give this talk. Oops. Okay, this is now my talk. So this was absolutely a fabulous question that I was asked to present on. So usually by the time someone comes to see me with cervical cancer, they've either got usually locally advanced disease or metastatic disease. So just some stock ownership, just for conflict of interest. So Australia, cervical cancer is the 3rd most common gynecological cancer, but worldwide it is the 4th most common for incidence as well as mortality. And this is based on WHO global data for women. And it's estimated that each year there are and 70,000 diagnoses of cervical cancer. So this is huge. We have some risk factors of which we know about HPV being a huge risk factor. Smoking, well, smoking's on the decline. Poor screening history continues to be a problem. And really the only non-modifiable factor is actually age. So, with good screening we have seen, and this is Australian Institute of Health and Welfare data, and I'm actually going to use a lot of their data for my presentation, that the incidence of cervical cancer is decreasing over time, and with that, the mortality is decreasing over time. If we think about HPV, it's not just one virus. There are actually multiple different strains of HPV, of which the two ones with high oncogenic potential are HPV 16 and 18. We then have two other common varieties which people will know about, which is 6 and 11. These are kind of more your genital warts. And we also then have some other viruses which we think are kind of moderate risk in their oncogenic potential. So there have been a number of vaccines which have been developed, and the one which is most recent and now in the Australian vaccination process is Gardasil 9, and this covers our high-risk oncogenic, our 6 and 11, which are associated with your wart viruses, as well as some of those moderate risk genes. So if we think about HPV, we know that we start with a normal cervix, we get an HPV infection, and more often than not, we will actually get clearance of that virus. About 10% are going to persist. But you may also, in that time, have some very sort of mild changes within the cervix. However, with persistent infection, there is going to be a percentage of people that are going to progress to higher grade lesions in their cervix and then ultimately develop cancer. So these figures are just a snapshot of data which was taken from a large US population, looking at what is the incidence of HPV. And in the 14 to 19 women, it was 25% and 45% for women aged 20 to 24. So that's quite high in very young women. And it's estimated that around 8 out of 10 women are going to have HPV at some stage. So if we think about, well, how often does HPV cause high-grade cervical changes or cancer? These are incidence figures over about a 10-year period, and they do really relate to which strain of HPV you have. So 17.2% for type 16, 13.6% for HPV 18, very small amounts for your other oncogenic, less oncogenic types, around 3%. So quite high incidence of having high-grade cervical changes if you do manage to get this virus. If we look at the HPV vaccine trials, there have been a number which have been done, and certainly there's been a whole range of different ones, including the ages, how many sexual partners that you may have had, and so they're not all kind of the same. They're not your young adolescent, never had any sexual exposure populations, but nonetheless, when they did these trials, they were able to find quite a marked difference in the rate of high-grade CIN or cancer, and their endpoint was CIN, not waiting for people to get cancer. So we have the Australian HPV vaccination program, which was introduced for girls in 2007 and then 2013 for boys. So at the moment we give Gardasil as a school-based program. For those under the age of 14, there are 2 injections which are given, and for those over the age of 14, if they've not yet been vaccinated, it's thought that they probably need 3. They don't respond quite as well, and so they prefer to give that 3rd injection. So, vaccinating, hopefully, all our school-aged children. Does this mean the end of cervical cancer? Well, we'd like it to eventually, but certainly in the near future, unfortunately not. So I thought of 4 main reasons as to why we're going to still continue to see cervical cancer to be a problem. We do have a large number of unvaccinated populations. We do need greater uptake of HPV vaccination. Cervical cancer screening, like all cancer screenings, has always been difficult. We need greater uptake there. And then also, finally, we do have an unmet need for effective cancer treatments. So just starting with the unvaccinated population. So if we go back to the inception of this program in 2007, we're looking really at vaccinating within year 7's age. So basically that's about 12 to 13. There is a catch-up program which is available for those up to 19, but also for older people who are not included, you can go to your GP and you can actually self-fund the vaccine. So if we sort of think about, well, what does that mean for our population? Most females over the age of 25 have not received an HPV vaccine. And if we look at the incidence of cancer, and this is by 10-year marks, so we can see that it's going down over time if we look at 10-year time periods. But what I just want you to appreciate is when those curves start going up, it's around the age of 25 and up where we're starting to see cervical cancer. So this is our unvaccinated population. The next problem is the uptake of HPV vaccine, and I'm going to read this out because I really find it not what I would usually recommend, but you know, this is a website, The Truth About Cancer, and it's not a favoured website by myself. Either way, millions of girls and young women have been tricked into getting an unnecessary vaccination for an unlikely disease while endangering their health now and in the future. Know the HPV vaccine fact. There are lots of people who do not like vaccination. But this vaccine is safe. It's been tested on many women. This is a safe vaccine, but unfortunately, there are a lot of people who do like to, for whatever reason, discourage people from having HPV vaccination and other vaccinations. So what are the vaccination rates? So again, Australian Institute of Health and Welfare, I got this data. If we look at girls in 2017, overall rate was around 80, so 1 in 5 not vaccinated. What impressed me was Northern Territory. How fabulous are they? They're winning. So, you know, it's a remote community. I thought that was really impressive, but 1 in 5 of us girls not getting vaccinated. If we look at boys, we want herd immunity. They're down at 75% roughly, so you're looking at, you know, they're 1 in 4 not getting vaccinated. That's not great. But we're also going to get some side effects. So while this has been principally developed as an HPV for cervical cancer vaccine, we've got all these additional benefits which are going to come along. And this is not only in vulvar cancer, but vaginal cancer, they are relatively rare, but anal cancers and head and neck. So we would expect with vaccination that we are not only going to get a reduction in cervical cancer, but get a side benefit from all these other cancers. Screening. Previous guidelines, we had to go get I say we as females, men, not you. In the room, us females were recommended to get pap smears every 2 years from the age of 18 to 69. New guidelines, which came in December 2017, said we had to do a HPV test every 5 years from the age of 25. And it included women who've already had the vaccine. So we want to make sure the vaccine is still doing its job, and to date, 10 years they're still collecting the data and it does appear to be holding, but we don't want to become complacent, so we still need to be checking those women. It does lead to a much more complicated sort of schema about what we do, but essentially if we detect HPV and we then need to do a pap smear, and then patients will then follow this different scheme depending on what it's found. But by and large, I would say that most women, if they're advised that they can just have this test every 2 years or change to HPV 5 years, look, I think it's an amazing change for females who love having their pap smears, but also it's more effective, and that's why we've changed how we screen. So these are going back to older figures of pap smear. Look, the rates are awful of screening. About 60% all up. And, you know, while it's a little bit better in major cities compared to remote, I'd actually say it's quite poor globally. And if you look at the socioeconomic data, You know, we often say that people of lower socioeconomic groups are not getting screened that much, and those of high socioeconomic groups much more. Actually, yes, a little bit more, but I still think very, very low. So why does screening work? It's because we get multiple looks. So screening is not a diagnostic test for cervical cancer, but we are trying to pick up early changes which will then lead to, hopefully with treating of these high-grade diseases or monitoring of the low-grade changes, prevent cancer. So if you don't have this screening, it's the poor screening history which is going to put you at risk of cervical cancer. So we absolutely need to emphasise screening. But we're not only bad at screening for cervical cancer. Women, our breast cancer screening is, I was actually surprised. I would have thought our breast screening figures were better than they were. Colon cancer screening, by the age of 50, you get sent a kit in the mail by the government. They're about 40%. So as a whole population base, we have very good screening, but we don't take it up. And this is really the talk about unmet need. So for people who are diagnosed with cervical cancer, their outcome is going to be related to the stage diagnosis. And for what I'm seeing for my patients, I'm often seeing people who've got relatively advanced stage 2A and beyond disease or metastatic disease. And so you can see for the group of patients that see me, their outcomes are relatively poor, and they are likely, unfortunately, to die of cervical cancer. Effective treatment, well, how do we treat them for early stage disease? It's often surgery. It's been mentioned, you know, with Di talking about endometrial cancer, but fertility treatments, fertility can be affected in these young women. We cannot always do fertility sparing surgeries. And then for the more advanced tumours, we're really looking at chemotherapy and radiation, which does have long-term toxicities for the patient. If we think about metastatic disease, that's my involvement, but we give chemotherapy with carboplatin paclitaxel plus or minus a drug called bevacizumab. But after you have failed first-line chemotherapy, unlike other cancers where I've got lots of different treatments that I can try, I don't have a second-line treatment. It is really best supportive care. So if we think about what have been the advances in 20 years, I could really only find two. So the NCI alert was in 1999. This was on the back of multiple trials of chemotherapy with radiotherapy. And it said that concomitant cisplatin-based chemoradiotherapy should be considered instead of radiotherapy alone in women with cervical cancer. And this was looking at about just shy of a 10% benefit in terms of local control and survival. The second one came many years later, in fact 15 years later. And this was when we found out the addition of bevacizumab to chemotherapy provided a 3.7 month survival advantage. And that's for patients with metastatic disease, people who are ultimately going to die of their disease. So that's it. And then if you're diagnosed with cervical cancer, has your outcome improved? We know that the overall incidence and therefore mortality is improved. But if you're diagnosed with cancer, have we done any better over time? That is a horribly flat line. So, in answer to your question, Karen, with the advent of immunisation, why is it necessary for cervical cancer clinical trials to continue? And my answer to you is to try and save the lives of thousands, lives and provide more effective treatment for the many hundreds of thousands of women who are going to be diagnosed with cervical cancer in our lifetime. And HPV vaccination is the greatest step forward to date that we have for preventing disease. And I'm an unapologetic, proud mother of these two beautiful girls. This is my Kira and Madison. They will be vaccinated when they get a little bit older, but we really do need to try our best to eradicate this disease. But we do need to continue because it's going to be some time before that occurs. So with that, I'm going to say thank you very much for listening, and I hope it's been very thought-provoking.
Could you tell me what the positive rate for HPV since they've been testing for HPV is? Like how many in 100 or 100,000 or whatever?
So basically it's incredibly effective. So to date, when they've done studies 10 years on to look at women who were in the vaccination trials, they do not appear to be getting HPV infections. So
No, after the current new paradigm as far as HPV testing goes, what's the positive rate as to negative rate?
I don't
So
have...
prevalence of HPV virus in the population. I think that's a question.
Oh, that's right. I don't know that data.
I hear there's a 6 month waiting list once they're positive to have to see a gynae. Is that right?
I see patients who've been diagnosed with metastatic or locally advanced disease, so I don't know those rates. I'd be very concerned if that was actually the waiting time.
And further, I hear that they're sent to family planning where the nurses do what the gynaes are doing, looking for white spots in order to overcome the shortage of gynecologists.
It's a little bit outside my area, so I'm a medical oncologist rather than a GP or someone who's in that primary health care. So I just a little bit outside where I think I can give you the right answer to the question that you have.
That's okay.
Beautiful questions, but I just don't want to give you the wrong answer by guessing.
That's okay.
Do you have any other questions?
Is there an upper age limit to when you can have the vaccine?
No, there's not an upper age limit. The problem is if you vaccinate older people, that they are very likely to have already been exposed to the virus, and it's probably not that effective in people who already do have that re-exposure. So when they did the trials, the preventative trials, there were women and they weren't selected for whether HPV positive at the time that they went in for the trial, and it's probably why you did see that incidence even in the vaccinated as well as placebo of people who had some changes. Most women, by the time that they reach their 20s, will have had HPV exposure, and there's also, I remember seeing another statistic when I was looking at this, is even after females' first sexual exposure, within a couple of months, the rate of HPV infection detected is about 30%. So it's just an incredibly prevalent virus.
Okay, thank you very much, Visceral. I think I better move the box though. I think I may be a little bit.
I'm sure the other presenters might fall in line.
Thank you, Michelle. We're going to break. We are running behind as we anticipated we might have been, but we are going to, I would ask ladies and gentlemen to go out and grab a cup of tea and something to eat and then come back in, and we will continue straight away. Coming up we have Wanda Lawson, who will be speaking, who's the chair of our Consumer Research Panel. We have the wonderful Dr. Viet Do speaking with regards to radiation oncology. And then we have survivors teaching students. So we'll be back hopefully in the next 10 minutes. So if you're watching us live stream, back in about 10 minutes. Thank you.